Kyle Schweizer, and I'd like to thank you guys for joining us for the Journal Club today on syndesmotic injuries. I'm joined with other moderators, Andrew Mills, Matt Riedel, and Albert George out of Southern Illinois, Yale, and Grand Rapids. And I'd like to thank them for helping us put this together and all the work that they did. Our faculty today, we have three authors, Prism Schneider, Anna Miller, and Mark Yakovanis, who will be presenting their research on different areas of the syndesmosis, including fixation, reduction, and the posterior malleolar component. And then we also are joined with a guest lecturer, Lori Reed, who will be discussing kind of her views on the syndesmosis and how we can treat and fix them. Here are the disclosures for the authors and moderators, and there's nothing relevant to this talk. AO North America staff does not have anything to disclose. And we would like to thank those who provide funding for all the education that we are able to do, and that everything that's presented here today is for educational purposes only. And again, AO is an independent nonprofit society and that is geared just towards education. So nothing that is said here will be to promote the use of any particular product. Everything is strictly just for education, and we will not endorse anything officially. Just a reminder of Zoom etiquette. Please have your microphones muted and your videos off. Participants can send all their questions through the Q&A box, and then the moderators will either answer them or will save them for the discussion at the end. And then faculty and staff can use the chat box to discuss issues with each other. Here's the agenda. We're going to cover 3 videos with authors and moderators discussing their papers. The first will be reducing the syndesmosis. The second will be improved reduction with a tightrope. And then the third will be how fixing the posterior malleolus is beneficial. After that, we'll talk with Dr. Reed and get some of her thoughts. And then we'll open it up and answer questions and do a discussion with all the faculty and finally wrap up. The objectives for this journal club, hopefully by the end, you can kind of describe different reduction techniques for syndesmotic injuries, compare and contrast different fixation methods, and then discuss some of the outcomes during recovery. And then we're going to give a shout out to the next journal club, which will be on August 16th, and it'll cover both bone forearm fractures. And then you can always access this recording by going to the YouTube channel for AO Trauma North America. That's where all of these are stored so that you can watch them anytime. It's a great resource and something that I highly recommend looking into if you have not. You can also join the page and get all of the updates. And so we'll go ahead and get started with our first video.
I'm Andrew Mills, and I have the pleasure of interviewing Mark Yakovanis, and we're going to discuss reducing the syndesmosis under direct vision. Where should I look?
Hi, thanks for having me, Andrew. So I'm here to talk about a paper that we wrote about the syndesmosis. So the reason why we did the paper is I think reducing the syndesmosis has always been a troublesome area for most surgeons that deal with ankle fractures and syndesmotic injuries. And there's been somewhat controversy in how you reduce it, both fluoroscopically, whether you use the incisura. And the senior author to the paper had a method where he would reduce it based upon the anterior joint surface of the ankle. And what we wanted to do was to see how that compared versus the other way of direct reduction, which would be the incisura. And so what we did is we used 10 cadaveric specimens and we sectioned the syndesmosis. And then we had a subset of surgeons reduce it both using the incisura as well as using the anterior joint line. And then we compared the two. And what we found was that when you use the anterior joint surface, so what we call the Mercedes sign, which is the joint surface about the fibula, the anterolateral tibia, what we found is that when you use that as a reduction model, you're over 90%, I believe it was 94% accurate in terms of reducing the syndesmosis versus using the incisura. And then the second part of the paper was sort of determining why that is, why you'd be more accurate with using the joint line. And what we found was that the anatomic variability, or the variability in the width of the incisura between the tibia and the fibula, was greater than that at the joint line. So we hypothesized, and we sort of proved, was that the joint line is more accurate because the width of the fibula and the tibia are more closely related at the joint line than they are 1 centimeter proximal in the incisura.
So, I came up with I had some questions for you. I mean, whenever I read a paper like this, I want to know, like, is this the way that you still do it, I guess? Or is this how you do it in practice?
Yeah, absolutely.
And then the other thing that I always comes to mind when I think about, this is, do you ever worry about putting this other incision on people, or, because it is an additional incision compared to what people have traditionally done, or what, most people do.
Yeah, so I mean, so there's very little I do in the operating room that I don't worry about. So that's a loaded question. Yeah, I think so. Absolutely, adding an extra incision is worrisome. I think what I try to balance is, I also worry about malreducing the syndesmosis. So, in cases where I'm very concerned about it, I think that the added benefit of having confidence in your reduction outweighs the risk of that incision, whether it be skin issues or a nerve injury. So, I think that it's a balance. And your first question was, do I still do this? And the answer to that is yes, I still do it. I don't use it for every syndesmotic injury. So I think that I'm very selective in terms of which syndesmotic injuries I'll use it. And what I found is that I'll more commonly use it on a Weber C fracture where there's a syndesmotic injury versus a Weber B with a syndesmotic injury. I found that when you use a Weber B, when you're fixing a Weber B fracture and there's a syndesmotic injury, for some reason I think the syndesmosis just tends to sit or aligns a little bit better versus there's a bit more instability with a Weber C fracture. So with a higher fibular fracture, I found that I'm using it more than for a lower fibula. I also tend to use it when I'm not, for a younger, somebody that I really want to make sure that I do everything possible to anatomically reduce the syndesmosis. If there's any case where I'm worried about the skin, or I'm worried about the patient's healing the skin capacity, an older patient, renal pain, of course, then perhaps the risks outweigh the benefits. So I never, certainly not an all or none, but what I do use it as, whenever there's any confusion, or even if radiographically in the middle of the case, I'm just not entirely confident, I think it's a great bailout option, or an option that I very quickly will go to sort of, double check and make sure that I'm doing it exactly right.
Okay. Yeah. So more likely to do it in a Weber C young patient, less likely to do it in a Weber B older, sicker patient.
Exactly. Or skin compromised. So.
Got it. So you mentioned fluoroscopic checks. So, let's say it's a situation where you're fixing the syndesmosis, and do you do the fluoroscopic? Which one takes primacy, I guess, for you?
Yeah, so I mean, I always like, as I'm sure most people do, to sort of double check both. So things should always add up. So if you anatomically reduce it with a direct reduction, fluoroscopically, it should look correct. And so if those don't add up, I will double check, both, and see perhaps there's rotation in the the fluoroscopy, or perhaps during the fixation, I lost some of the reduction. So I'll always double check both. But I think the crux of the issue you're saying is which one do I have more confidence in? And I mean, the direct reduction, I would say I have more confidence in. I think that, you know, personally, I just feel like, you know, seeing it directly reduced, I'd have more confidence than I found that with fluoroscopy, there's a lot of rotational changes or things that might, you know, might give you a false sense of confidence or a false sense of peril. So I'd have more confidence probably, or definitely, in the direct reduction, but I'd like them both to add up. And certainly if they aren't adding up together, I would check both.
I gotcha. All right. One other thing I wanted to ask, you know, they mentioned, you know, you mentioned in the paper the use of 3D imaging in the operating room, and I've heard that advocated for before.
Yeah.
You know, do you think that, I guess so, if we, you know, project ourselves 20 years into the future, do you think this will still be something that we do if everybody has access to like a 3D CT scan?
Yeah, I mean, I certainly think that it will, because you know, particularly with an O-arm, there are definite costs associated with that, both operating room time. Now you can make the argument that a separate incision is going to take some time, but you know, really small incision, and once you do it, you get pretty facile. And bringing in an O-arm, protecting everybody from the radiation, I think that there may be an argument for that, but particularly in my hands, I think there's going to have to be a very strong argument, because I think the direct reduction has a very strong role, and it's something I'm very comfortable with. And you know, perhaps they'll find a way to do the O-arm very efficiently, but I don't know how that's going to happen. I think it's going to be very slow. And this is something that I'm very comfortable with. I think most surgeons would be very facile and comfortable with after doing it a couple times.
Yeah, no, it definitely seems like it, because it doesn't seem like it's much of a skin incision.
Correct.
It seems like it's a pretty good bridge, and it gets you right down there. Plus, it seems if you're comfortable operating around the foot and ankle, the nerve issue is not something, I mean, something you're worried about, but you know, not something that's causing you undue anxiety.
Exactly. As long as you're aware, if you're aware of it, you know, if you're aware that that is a potential complication and you're very careful, then you should be able to avoid long-term effects.
Okay. All right. Well, you know, I guess the last question I'd have would just be, you know, what was the most interesting thing that you thought you learned on this paper? What was the big thing that you got out of it, if you could point to one thing that you learned? I mean, maybe you said it already, but
yeah, no, I think the biggest thing that I learned, or the biggest thing that I gained from it, was having a great deal of confidence. So I know that, you know, I feel when I do the direct reduction and I leave the OR, I just have, you know, a significant amount more confidence that it is correctly reduced. And I think, so it's not necessarily learn something, but I have much more self-assurance when I perform that everything is correctly aligned than I would have, you know, otherwise. So I think that when you see, perhaps you're less likely to get, and I don't routinely, but I'd be less likely to routinely get a postoperative CT to look for the syndesmotic alignment, or I just gain a lot more confidence. And I know that's, so if ever I'm struggling and you need something to sort of just reassure you that you've correctly reduced, I know that this is in my bag of tricks and that it's a great tool.
Yeah. No, I thought this was a great paper, and I just wanted to say thanks for your time, and thanks for agreeing to be interviewed and adding your voice to this discussion.
Yeah, absolutely. Thanks for having me.
Hey everyone, good evening. My name is Matt Riedel. This is part of the AO Trauma Journal Club session, where this session is on syndesmosis injuries. I'm proud to introduce Prism Schneider. She's an associate professor of orthopedic trauma at University of Calgary, and that's in Calgary, Alberta, Canada. She's the author of a study entitled Improved Reduction of the Tibiofibular Syndesmosis with Tightrope Compared to Screw Fixation, Results of a Randomized Controlled Trial. It was published in JOT in 2019, and I'd like to thank you for joining us tonight to discuss the paper, Dr. Schneider.
Great, thanks for having me.
My first question for you is why did you guys decide to do this study? What proposed it for you guys?
Yeah, thanks very much for the opportunity to chat about our research, of course. And I think the motivation for this study really spanned the entire COTS group, so Canadian Orthopaedic Trauma Society. And we recognized that there was still this residual, very high malreduction rate of syndesmotic injuries. Literature at that time was over 50% malreduction rates of the syndesmosis. And there was fairly good literature to support that even a malreduction of 2 millimeters, pretty small malreduction, could really impact functional outcomes. And so we started to pose the question, why would we sort of think that dynamic stabilization wouldn't make more sense in crossing a joint? So with static stabilization using screws, of course, we're limiting that natural motion that occurs between the tibia and the fibula. And so I think this was a unified question clean across our country that led us to really study this in a systematic way.
That's awesome. And one question that I had, I know you only studied syndesmosis injuries that had been stabilized with the plate and screws. Did you find any issues with length stability with the tightrope?
Yeah, so that's a fantastic question. And I do think it's an area for future and some ongoing research at the moment. And so I think that's a really important point in our inclusion criteria. So what we did was we did randomize patients preoperatively to either static or dynamic stabilization. And then the first step was actually stabilizing any malleoli fractures. So if there's a medial malleolus fracture, that was stabilized first. And certainly if there was, these were Weber C, AO, OTA 44C type fractures. So we had to stabilize the length relationship before proceeding to stabilizing the syndesmosis. We did have to ensure that once we had fibular length and a medial malleolar injury was stabilized, that there was still instability. As you know, sometimes we get it wrong preoperatively with our radiographs. And so we had to ensure that there was still at least 2 millimeters of displacement between the tibia and the fibula to define dynamic instability of the syndesmosis and then proceed with the treatment that they've been randomized to. That is an important distinction because we did not include patients that had, say, a high proximal fibular fracture where it wasn't fixed surgically, so there would be that length instability. There's some ongoing research and some work that we're doing, and I know in other groups as well, where we're looking at the utility of using dynamic stabilization with two tight ropes or dynamic stabilizing suture buttons placed divergently to help address some of that length stability issue, because I think that is a really important point. With a single dynamic stabilizer, there is concern that there can be displacement of the length unstable fibula.
Yeah, I think that's a great point. That's one thing that I do. I'll often make 2 points of fixation, whether I use dynamic or static stability, and make them a bit divergent in the A to P plane for that reason. I noticed that you guys proposed 3 cortices versus 4 cortices. Is that a standard of practice at your institution?
Yeah, also fantastic. One of the wonderful things about the COTS group is there's lots of debate with protocol development prior to beginning a study, and that certainly was an area of discussion. There are definitely practice pattern preferences for sure. It seemed to be that that was more standardized across Canada. We did not propose routine removal of screws, and so we decided on the tricortical fixation. It is interesting to note some other studies that do compare dynamic stabilization with screw fixation have used quadricortical screw fixation and have found very, very similar, if not identical, results to what we've reported.
And that leads into the next question I had for you was the hardware removal rates. I know that you had noted some surgeons electively remove the screws, some surgeons elected to remove them only if the patient had an issue. Is that surgeon dependent, or is that is there a standard that you guys follow?
Yeah, an excellent question again. And so we've tried to encourage surgeons for protocol purposes to maintain the screw fixation until at least 1 year, which was our final follow-up. However, some certainly elected to, based on patient symptoms and things, and we certainly didn't dictate that that was mandatory. And so we did have some screws that were removed on an elective basis. But what's interesting to note is despite that, our reoperation as well as the hardware removal rate was significantly higher at 30% in the screw group compared to only 4% in our Tightrope group. I will also take note of the paper by Anderson et al. And so that was in JBJS the year preceding our paper. And interestingly, this was a 2-center RCT. They used a single screw and a single tightrope. And they actually planned screw removal for all of their patients. And kind of regardless of that, there was still, a difference in their reoperation and complication rate in favor of the tightrope group. So that's just an interesting thing to note. So I would say Canadian practice right now is still a little bit variable, but for the most part, unless the patient is symptomatic, we are leaving our syndesmotic screws if they're used in situ.
Okay, so you can say that that increased hardware removal rate was due to patient symptoms and not necessarily surgeon preference?
Correct. I think there is a bit of a combination, but to tease that out, it was more that the patient was symptomatic enough to warrant removal.
Good, perfect. I know you followed the patients for 12 months. Anecdotally, do you have any longer term follow-up on any of those patients?
Thank you for asking that anecdotally, because we have continued to follow our patients along for longer term here at the lead site in Calgary. We've actually performed CT scans at 1 year, and I'm excited to tell you about some additional imaging that we're doing as well. And so one of the initial concerns with the dynamic stabilization was maybe loosening over time. And so we have been able to demonstrate in our cohort that that isn't the case. The dynamic stabilization reduction is maintained at least at 1 year, and we are trying to follow these patients longer term. We have that manuscript under review at the moment.
That's really cool. If you could do the study over again, is there anything you would change or do different, either protocol or just, through the experience of doing it, looking back?
Yeah, fantastic question. I think that whenever you're doing a multi-site randomized trial, there's always so much to be learned and things that you would improve upon. It is interesting, I think collectively as an orthopedic trauma group, one of our challenges is longer term follow-up. So ideally, of course, we'd follow these patients for 5-10 years. That definitely lends itself to some challenges when you're looking at funding agencies and getting support for these studies. And that's a big barrier, I think, to some of our longer term research. So ideally, we certainly would have had longer term follow-up. And what was interesting to note about our study was our primary outcome was actually malreduction rate based on the CT scan at 3 months. So we acknowledged that we were underpowered to measure a difference in patient-reported outcome measures. We did use the FADI, so the Foot and Ankle Disability Index, and the Olerud-Molander score. And so we did do a post hoc sample and size calculation, and we do require about 250 patients in order to look at that functional outcome difference. So that would be nice as well. The only thing that I would say that's quite interesting is, again, choosing that outcome measure appropriately. So again, the Anderson group, very similar sample size, followed for 2 years, and their primary outcome was actually the AOFAS, so the American Orthopaedic Foot and Ankle Society score, and they were actually able to show a significant difference in a patient population of just over 100 patients. So following these patients a little bit longer, really ensuring that we're using the proper patient-reported outcome measures, I think is really important.
That's great. And I have to commend you guys. You had 85% follow-up at 1 year, which I don't know if that's Canadian patients behaving or you guys just had patients that really enjoyed seeing you guys. But that was
I like that. Maybe we'll go with the latter, but no, we do pride ourselves in our follow-up. We try really, really hard. We know it's important.
and I know we touched on this, but any future directions? I know you said it's currently in process with longer term follow-up, but any further ideas or thoughts that you guys have had as a group going forward from this study?
Yeah, I appreciate that question because we are really excited in a branch of research that we've been undertaking. We have had the opportunity to present some preliminary findings at the OT meetings We are using 4D CT, so that actually allows us to observe a patient taking their ankle through a full range of motion, because I think one of our limitations right now is all of our intraoperative imaging, all of our CAS clinic follow-up imaging is all static, and this is really a dynamic problem, and the complaints that the patients have are very much dynamic in nature. And so we're learning a lot by actually using this dynamic CT. So we now have a group of patients outside of this RCT, so screw and tightrope fixation. We're actually looking at posterior malleolar fixation as well. And so that's really helping us to evaluate reduction through an entire range of motion. And a little sneak peek, I guess, on that is we certainly are showing the potential advantages are carrying through for dynamic stabilization of the syndesmosis throughout a range of motion. And, you know, that really does lend itself to the findings of improved patient-reported outcome.
Fantastic. Well, I thank you a lot. These were great discussion points. I think I look forward to seeing what the participants have in terms of other questions for you. But are there any parting thoughts or mentions that you wanted to make about the study or just the syndesmosis in general?
I think you've actually highlighted it, the fact that there's still such an area of need with length unstable fractures, with new technologies, with new imaging sources. And so I really do think that we still have a lot to learn in this area, and it would be great to do that collaboratively, because that's the way to really, I think, get to the bottom of a lot of improvements that are yet to come for our patients.
Absolutely, I agree. Well, thank you for your time. I look forward to the discussion that we'll have coming forward. And thank you again for joining us.
Wonderful. Thanks for having me. I really appreciate it.
I'm here with Dr. Anna Miller from Washington University, St. Louis. She's coming to talk about her paper on posterior malleolar stabilization of syndesmotic injuries is equivalent to screw fixation. Dr. Miller, thank you for joining us.
Thank you. Thanks for having me.
So first question I had is kind of what the story behind the study was. I know there's some previous studies before this and some studies that came after this out of HSS, and just curious what that whole background was.
Sure. Maybe the most studied joint in the entire body in trauma. I think we've all had maybe a little too much of the syndesmosis, but when I was a resident, Mike Gardner, who's now at Stanford, was a couple years ahead of me, and he had worked with Dean Lorich on this kind of topic originally. And they had some papers where they kind of looked at malreduction and how maybe we're not doing as good of a job as we think of repairing the syndesmosis. And essentially the idea behind it was, if we're fixing most joints to make them a perfect reduction, why are we not doing that for things like the syndesmosis? And maybe some people would also argue things like the SI joint or the symphysis in the pelvis. So Dr. Lorich was a very innovative guy, one of my biggest mentors who we all miss. But he always was kind of thinking outside the box. And he thought, again, if we know that we're doing a bad job of fixing the syndesmosis with screws and it's not anatomic, then maybe it would be better if we just fixed the actual piece that's broken, which is usually the posterior malleolus attached to the PITFL. And they're very lucky at HSS because they have Hollis Potter and the most amazing musculoskeletal radiology department. And they also have an amazing group of people who do MRIs. So he had kind of an ongoing research project getting MRIs in a lot of ankle and tibial plateau fractures. So we got a lot of information, and a lot of papers came out from that group about what is actually injured in the soft tissue, because obviously we focus on the fracture and we kind of don't think about the soft tissue attached to it all the time. And what they found was that the vast majority of the time, the PITFL itself is intact and it's still attached to that dangling little posterior malleolus piece. And then there were some other studies that we talk about in our paper that are much older studies that are actually more in the sports literature, where they looked anatomically at the syndesmosis, and essentially found that the posterior inferior tib fib ligament is probably the strongest part of the syndesmosis and the most important. So if we repair that, the theory is fixing the posterior malleolus, thereby repairing that, will be just as strong. And maybe we don't have to do screws and we don't have to poorly anatomically fix them. So we kind of did two congruent papers because they had already shown that we're doing a bad job, but we wanted to kind of prove that it actually works. So there was another paper around the same time as this one, I forget which one came out first, in one of the foot and ankle journals, where we actually looked at whether we directly reduced that piece and then got post-op CTs. And indeed, we found that if you fix that piece anatomically and then get a CT versus fixing them with syndesmotic screws, we are much better at it. So it makes sense that if you're putting a piece back, you're going to do a more anatomic job. But what we didn't know is, and that was the point of the paper that you and I are discussing, does it matter to the patients? Because again, a lot of these things we've been doing for decades. Syndesmotic screws have been put in people for many, many years, and people seem to do pretty well. So does it really matter if we have a more anatomic CAT scan? And what this paper showed that you and I are discussing is that indeed the patients did have better functional outcomes. And that is actually the bigger thing that we wanted to prove. The problem, of course, with this paper is that it is a really small group. And I think there has been a lot more literature after it that, you know, has looked into this, but that was the original idea. Like, first, we know that fixing it anatomically is better on CAT scan. Now, can we show that it's better for patients? And it is. However, there's a weird group in there, which is patients who kind of had both. And I actually asked Dr. Lorich because, you know, he was a guy that, like many of us orthopedic surgeons, had kind of a big ego, and every once in a while you have to poke him so that he, you know, would kind of spar with you. So when we were talking, I was like, okay, if you really believe that fixing the posterior malleolus is just as good as syndesmotic screws, then why do you have all these patients with both? And he was like, I'll be totally honest with you, Anna, I didn't totally trust it. So he had to prove it to himself too. So that was kind of cool to see that, like, you know, even he didn't totally think he knew all the answers until he had proven it. So that's kind of where the paper came from. And I think it really helped us believe that the anatomic fixation also is potentially better for patients functionally.
It's really interesting. And correct me if I'm wrong. So when I read this, I thought I had interpreted it as it's equivalent, or was there actually a functional outcome difference in people who had posterior malfixation versus just syndesmotic fixation alone?
You're right. It really does show that it's equivalent more than not better. And I keep saying better because it has the combination of being better radiographically and equally functional. So it is not, we did not show in this small group that functional outcomes were better. And, you know, I think the other argument about the paper is that maybe FAOS score is not the best outcome score to use. It's just that these patients had all had that, so that's what we used. But, you know, I think they're more follow-up with more specific functional outcomes, more patient-reported outcomes is probably even more important. You know, them telling us how they feel versus us telling them how they should feel could, you know, really help tell the answer to that. And then, of course, if we had more patient numbers, which at this point we obviously would, because a lot of us are treating these this way, but early on, that was all the patients that we had. So it was kind of, you know, just those first sets that had been done.
At that moment in time, you say within the orthopedic trauma community, how many other people were fixing the posterior mal in the way of avoiding to having to do syndesmotic fixation? Was that
it was really uncommon. How I couldn't tell you an exact number, but this paper was actually chosen that year. I was my first ever podium presentation at the OTA was this paper. I was super nervous, and Dr. Tornetta gave a talk right before me on one of his papers. And I sat down and I was like, I'm sitting by Paul Tornetta. This is so cool. And he was like, good job, but, da, da, da. And of course he had his own complaints about the paper. But, you know, I think it was very controversial. And, you know, as a resident, I just lucked into it in the timeline because they had been progressing through it. But everybody kind of thought it was ridiculous at first. Like, why would we switch away from syndesmotic screws? That little piece is so tiny. What's the point in fixing it? The historic literature always said you don't fix a posterior malleolus until it's greater than 25% of the joint. But when I talk about this now with our residents, and if I go give a talk on ankles, the 25% was a historic number based on axial load, like a pilon fracture, and that is the size of the joint that would give the patient instability for the entire posterior part of the joint not existing anymore, which is a completely different conversation than a rotational ankle injury with the PITFL avulsed off. I mean, the posterior malleolus avulsed off with the PITFL. So you're comparing apples and oranges when you start talking about the 25% thing. So we're talking about much smaller posterior malleolus fragments that are a rotational avulsion injury and fixing those anatomically. And nobody had really done that before, as far as I'm aware, before Dr. Lorich started thinking about that and doing it anatomically.
And then, you know, you mentioned there's that group that got combined, posterior mal and syndesmotic fixation. I believe those are all patients with fracture dislocations.
Yeah.
Has that changed over time? These patients with fracture dislocations were either for him or for you, did they keep getting syndesmotic fixation at the same rate, or did that decrease over time?
Definitely decreased. So that was kind of part of our conversation, but now I don't fix any of them with syndesmotic screws unless there's something else going on. Like if they have really bad diabetes and I just want more solid fixation, I'll do it as an additional, you know, vest over suspenders or whatever. But he literally just did it because he didn't trust his own guess about what was happening. And once that was proven and all these studies were done, he did not do the combination anymore as a routine. And I don't, if they have a fracture dislocation or, you know, just a fracture, I think if the fracture is fixed and the ankle stable, I don't add extra syndesmotic screws. To me, that doesn't really make sense unless there's something else going on.
What would you say are the major takeaways from the study?
I would say major takeaways are that if we consider a posterior malleolus fixation, we know it's more anatomic, and we certainly have at least equal outcomes functionally, according to the FAOS, comparing posterior malleolus fixation and syndesmotic screws. So certainly I would encourage everyone to consider anatomic fixation of the posterior malleolus when it's feasible.
Yeah, thank you very much for joining us. I really enjoyed this, and I'm sure everybody else listening is going to enjoy this, and looking forward to the discussion we're going to have on the live session.
Yes, hopefully I can make it. Thank you again for having me, and we'll enjoy the discussion.
All right, so that was good. We've got some questions that we'll go over kind of at the end through our discussion and answer with the authors. But right now, I was going to talk with Lori Reed about some of her thoughts on the syndesmosis and kind of touch on maybe some areas that we didn't cover with these papers. So Lori, thanks again for being here. How are you diagnosing a syndesmotic injury intra-op? Like, what test are you using? Because there's a few out there, and the residents always ask, me like which one I prefer, but how are you determining if there's actually an injury?
So I use the external rotation test. I haven't used the cotton test for a long time. I just feel like the external rotation test tends to be a bit more functional than sort of what you do during a cotton test. But
okay. And then once you've determined that someone has a syndesmotic injury, do you are you opening and reducing these? Or are you doing it closed? How are you making that assessment of when you're going to do either one?
yeah, so I guess what I always start with is getting, if the other side isn't injured, I always start with contralateral imaging. So we always get a mortise view and a lateral view of the contralateral ankle, and I try to match it closed. And if I can't match it closed, then I open it. How do I look at it? It kind of depends. I am very not dogmatic, unfortunately, but I do think you get a more accurate reduction by looking at the anterolateral corner of the ankle versus the incisura. Sometimes the incisura is so shallow, it's a little bit hard, particularly if they're really unstable. Sometimes you can put the fibula anywhere if their anterior and posterior syndesmotic ligaments are out. And so for sure, then I'll look at the anterolateral corner to make sure I've got it okay.
And are you looking at on fluoro, or are you doing an open approach to look at it?
Yeah, open approach. If I can't match them closed on fluoro, if the injured side doesn't look exactly like the other side, then I will open it.
And are you doing a separate small incision, or are you kind of sneaking over from your lateral incision?
Yeah, so I sneak over from the lateral incision. Usually I don't make a separate incision. I kind of J the distal aspect of it. I make it I bring the incision a little bit further distal and then J it anterior and just lift a full thickness flap. Just taking care, I think I do that. That's sort of how I get to Chaput fragments as well. But you can get there pretty easily. Just be careful that you're not lifting off ligaments when you're doing that, or making your own syndesmotic injury. Now, I don't see much of a downside of doing a separate anterolateral approach. This is just kind of how I've always done it. Yeah,
and that was a question that was proposed, and I was going to ask the rest of the authors about it too, how they do it. I curve it like you anteriorly along the sinus tarsi, and I think that's an important, if you're going to come from the lateral side, I think that's an important technical thing to understand, that it's hard to move that skin flap enough over the anterior aspect of the ankle to see without that kind of anterior curve to lift that skin flap. So,
and I truthfully, if I think that I might do that, looking at their initial imaging, I'll make a more straight lateral incision versus I tend to use a more posterior lateral incision. But if I think I'm going to sneak over the top and J that incision distal, I'll make kind of a straight lateral incision, and I feel like it's just a little bit easier to get there.
Yeah. How aggressive are you with fixing posterior malfractures that aren't kind of that traditional, like larger fragments?
Yeah, I don't know. I wish somebody would give me an answer as to, if you measured this is what you should fix, because I look at a lot of them that are, smaller and smaller and smaller. I don't fix all of them like Anna does. I wish I had a great answer that I could tell you this is exactly what I fix. If I think if it's big enough, I also don't, certainly smaller than 20% of the joint surface. If there's anything sort of intervening fragments that I don't think I'm going to get the posterior mal aligned, particularly if there are intervening fragments that are prominent and I feel like are going to put any pressure on the talus, then I definitely will open that posterior, open the posterior lateral approach, or, address that, flip the fragment back as best I can and take those intervening fragments out. I will say that, I finished residency in 2004. and we never did any direct approaches to the posterior mal that I remember. And then everybody kind of started doing them. And so, I started doing more and more and fixing smaller and smaller fragments. And, if Anna is on this, maybe she can talk about this a bit, but I don't think it's a completely benign approach. I sometimes have problems with people getting their dorsiflexion back after doing that approach. And I think I'm careful. I mean, you have to take as much of the FHL off of the fibula as you have to take off to get to that posterior fragment. And sometimes it's a bit more than you think, depending on how high that fragment is elevated and if you're going to, put an anti-glide plate back there. So, I started doing them more and more, and I started putting them on smaller fragments. And then I sort of had some patients that had a tough time getting their ankle dorsiflexion back. They just were stiff, or they had some tightness in their FHL. So I've kind of gone back the other direction, and I probably don't fix as many as I did for a while. And, I didn't answer a great question. I didn't answer probably anyone's question there, but I do think it's better. I think for sure you're going to get your reduction of your syndesmosis more anatomic if you fix that posterior malleolar fragment. I just don't know exactly which ones are the right ones to, fix. And I don't fix the little tiny ones.
Yeah. I mean, that's a tough, that I don't think that has fully been answered. There are papers out there that show it's the biomechanical stability is better than with the fix of the screws. And there's some smaller papers that show the functional benefits. I'm pretty aggressive with posterior malleolar fractures, but again, it's hard to know, I'm using sometimes some arbitrary stuff that I've come up with, like age, like how old are they? Like if they're in their 50s or 60s, I'm not going to be as aggressive as someone in their 20s.
Yeah.
Comminution, things like that. And so that's a tough question. And I appreciate you trying to answer it.
Sorry, I made more questions than answers on that one, but
what do you think has changed in your practice in the past 5 years in regards to the syndesmosis?
Yeah, so I use more flexible fixation. I wouldn't say I was against it, but I'm a little old school. I don't really usually jump on the bandwagon of all of these sort of new things. But I do use more flexible fixation. I don't use it in everyone. I tend to use it in younger patients, certainly athletic patients. I'm at Indigent Trauma Center that we have a ton of not healthy and bigger people that, they walk. That's all they do. They don't play sports. They don't, I joke, but, they like, if they're running from the cops. They're not like playing tennis or playing football. So that's my patient population. If I had a patient population that I was taking care of more sports injuries, I probably would use more flexible fixation. I certainly put it in, young kids that come in with, that have ankle fractures from sporting injuries or patients that have, I guess, anybody that's younger. So that's probably the biggest thing that has changed. But I will tell you that I still probably I rarely use 2 points of flexible fixation. I almost always put a screw in. And I rarely take screws out. And I just saw a kid today who is a football player. He's going into his senior year. That my goal was to take, I put a syndesmotic screw, I put flexible fixation in. My goal was to take a syndesmotic screw out at 4 months. He said, I'm not interested. My ankle doesn't hurt. I'm doing great. It's hard for me to talk that patient into going back to the operating room to take that syndesmotic screw out. I saw him today. He's 6 months out. He broke his syndesmotic screw. He doesn't care. His ankle doesn't hurt. So I don't know. It's hard for me to go back in and again, try to talk him into taking his syndesmotic screw out. Now, I will go back in and take syndesmotic screws out if people have pain or if they have problems with their ankle dorsiflexion. And I think John Ketz paper a couple of years ago showed that patients definitely do better if they have intact syndesmotic screws and they have pain if you take their syndesmotic screw out. So I don't plan to do it. It's not sort of in my protocol, but if anybody has problems with anterolateral ankle pain or has problems getting their ankle dorsiflexion, I will I'll certainly take a syndesmotic screw out.
Okay. And then
I
one
do
thing we
scope
did,
their ankle at the same time, but I do a lot of foot and ankle, so whatever.
yeah. What one thing we haven't touched on is post-op protocol. So what are you doing with these patients post-op? When are you letting them move? When are you letting them weight bear? Things like that.
Yeah, so if they are, relatively healthy patient that I sort of trust, I splint them all for 2 weeks. I keep them all non-weight bearing for 2 weeks. If they have a syndesmotic injury, I'm pretty conservative. I still keep them non-weight bearing for at least 8 weeks. Some people do less than that. I get it. But I tend to be relatively conservative. But when I see them back at 2 weeks, I put them in a boot. I just teach them range of motion exercises on their own at home. I have a lot of patients that don't have insurance that can't get to physical therapy. And so I just teach them on their own at home. And then once they can start weight bearing, that's sort of when I send them to physical therapy if they have access to it. If it really seems like at 6 weeks that they are struggling to get their motion, I'll send them to therapy a little early.
Okay. Well, thanks for
Yeah.
talking with us, answering some questions. If we can get the rest of the faculty and moderators to turn on their cameras, and we'll kind of ask some questions. Some will be specific to kind of individual papers, and some will be just to the general, population about what are you guys, doing with these. We had 2 questions for Dr. Yakovanis on, Lori and I kind of talked about it. Are you making a separate anterolateral incision, or are you sneaking it over?
Yeah, so this was largely covered. Is covered. I also do the J. So I sort of determine a little bit preoperatively if it's going to be necessary, and so I less commonly will find it necessary to do an open reduction in a Weber B fracture. But if you are worried about that, that's when I would try to J that anteriorly, so you can sort of flip it over, versus what I typically do is a more posterior incision, and it's really hard to gain access. And if you're more posterior lateral, you'd need to do that separate anterior incision. Now, for the Weber C, if you're going to fix the fibula, then I do a separate incision. So more commonly, it is a separate anterolateral incision. If it's going to be a Weber B, then I would, as you guys had discussed, J it a little bit anteriorly to make it easier to access.
Any other faculty do anything different when they have to open it? Okay. I think everyone is the question was probably proposed because they're worried about that skin bridge for the 2 incisions on the ankle. I don't know that if you're ever in a situation where you've made an incision and you think you now need to open it and you can't really get to it without doing a separate incision, there are some papers out there that show that it's pretty safe to make those incisions. It's hard to be in that traditional kind of 7 centimeter bridge stuff in the foot and ankle. It really more depends on length of the incisions, and the angiosomes in that area are pretty safe if your anterolateral incision is small. So if that was kind of the thought process behind, do you make a separate incision? It is okay to do that. You just have to respect the soft tissues while you're doing it.
Yeah, it's also it's become more common to scope, a lot of ankle fractures, and you're only extending that maybe 1 more centimeter if you're going to do an open approach. So.
One thing I like to talk to my residents about is the overlap. So the overlap of the incisions, a ratio of 1 to 1.5. So if you're overlapped a centimeter, as long as they're 1.5 centimeters apart, those angiosomes can get in and supply that skin bridge. So it matters, if they're overlapped a whole amount, then that's a big problem. If they're barely overlapped, that corner is not going to be a problem.
Yeah, I think there's some literature in plastic surgery with their rotational skin flaps that I think if the smaller incision, if the bridge is greater than half of the length of the smaller incision, then you should be fairly safe.
Yep.
And then Prism, there was a question for you in your paper on how did your team decide on CT measurements and directionality, like whether that is a 2 millimeter or 10 degrees of rotation, like that defines your malreduction?
Yeah, thanks very much. As I sort of mentioned in the video, there was a lot of hashing out the protocol prior to beginning the study, and this was obviously another point of discussion for sure. And certainly the literature at that time supported, either that 2 millimeter displacement or 10 degrees of malrotation. So that's what we selected. Cloud Saji has a paper in JOT. There's quite a bit of support throughout the foot and ankle sports literature for those parameters. And so that's what we endeavored to use as our criteria. And it's important to note we said or, so it was one or the other was defined as a malreduction.
I have a question for Dr. Miller. Are you fixing all posterior mal still? Like, are you being that aggressive, or if you kind of swung away from some of them, or what's your approach in that situation?
So I think I'll add on what Lori was kind of talking about earlier. I didn't know if I was supposed to jump in or not, but yes, in general, but I do not fix them in the elderly. So I guess I should say physiologically elderly. So, if they're a really sick patient, elderly, I don't want to put them prone or on their side. I'm going to put in syndesmotic screws, even if they have a posterior malleolus, unless it's that greater than 20% one that really is going to dislocate out the back if you don't fix it. So I don't fix them in the elderly, but generally anybody who I can see a piece that's displaced on the CT, I will fix. Somebody in the chat asked, and I replied to it, if I'm using suture anchors, or some people use soft tissue washers for just an avulsed like POTFL without even really a big enough piece to fix. And for me, I don't fix those with soft tissue fixation. So I would only fix it if it's actually big enough. But I do think your point is really good, Lori, about the difficulty moving afterwards and people getting like a stiff big toe where they can't pull their big toe up and it drives them crazy. So I have seen that. Obviously, we all have issues with our approaches from time to time, but the things I've done that I think are really helpful that have made a big difference for me, and I definitely do not see the FHL issue as much. I do a buttress plate for all of them. So I do a pretty big dissection to do the plate on there, but I make a real effort on the way in to keep the muscles in their own sheaths so they stay in their kind of fascial covering. And then when I'm manipulating it, I actually use the widest Homan I can find, or retractor, so that you're getting a really broad surface area, because I think part of the damage to the FHL is just done by the injury. But part of it is things like putting in a self-retainer or putting in a narrow Homan that like presses on it for a long time and then it gets beat up. So anything you can do. And then of course I try to like relax whenever I can on the soft tissue, but being really as delicate as you can with your dissection and retraction, I do think it makes a difference. And then I don't actually usually splint them. I know some of my foot and ankle partners will splint or cast them for like 6 weeks. And I really try to let them get moving right away, which I think also really helps, and encourage them to start moving their toes right away, so they're not like immobilized and potentially getting stiff in that way. So hopefully that answers the question.
I think that's a great point, Anna, of having to move their toes early, because I think sometimes that's why their FHL or their big toe gets tight. And I wouldn't have always thought to do that, but as I've seen a few patients with that, I do try to think to remind them to do that early.
Yeah, they totally forget. And I even tell their, significant other or family member with them, I'm like, every day grab their toes and wiggle it for them. And they're looking at me like I'm crazy, but I think it makes a big difference.
It's also good to prevent the blood clots too. It's just that
Yeah.
toe squeezes are important.
Yeah, I would say most of my patients, when I tell them to move their big toe or have someone else do it, they come back to clinic like I've never told them that before. That's a pretty specific thing to talk about, but it just shows kind of what patients do and don't remember sometimes. What is everyone else doing? We talked to Lori about what she's doing. What are you guys doing post-operatively in terms of like, when are you letting them weight bear? Are you putting them in a cam boot at some point? Like what's your post-operative protocol for these? We can start with Anna and then Mark and then Prism, just because that's the order on my screen.
Sure. So I have become much more aggressive over the years, partly due to some people on this call's work, but I do think we can let people walk sooner. So basically any injury that I have on any patient, ankle or otherwise, I let them start weight bearing at 6 weeks at the latest. So everybody at 6 weeks starts toe touch and advances to full weight bearing over the next 6 weeks. So by 3 months, they're fully weight bearing. And really the only exception I have to that rule is a true diabetic with neuropathy with true syndesmotic injury, like ligamentous, not just bony injury. Then I will make them stay off of it for 8 to 12 weeks, but everybody else I advance and I give them a cam boot at the beginning. So like I said, they can start moving their ankle and getting it moving right away.
Mark?
So I'm still probably in the non-weight bearers anonymous club. Unfortunately, I do try to get them into a walking boot or a non-walker as soon as possible and let them move their ankle at about between 2 to 4 weeks. But I haven't been letting them officially, by my recommendation, bear weight until 8 to 10 weeks for non-diabetics. And then the diabetics, I usually tell them not to bear weight for 12 weeks, but God knows what they're doing against my recommendation. They're probably putting weight on it the day after the surgery. So, but I agree. I think we can be a bit more aggressive, but I still 8 to 10 weeks is usually where I fall.
Right. So I think Mark's actually highlighted exactly what I was about to say, and the fact that there's what we tell patients to do, and then there's what they actually do. And so one of the things that we're working on at the moment is actually early weight bearing with dynamic stabilization. And so I do think that we can probably get people going a lot sooner. And this is with an isolated, length stable, fibulas fixed, dynamic stabilization of syndesmotic injury. And so I think pretty universally up here anyway, early range of motion right away, and then progressing weight bearing, even beginning at 2 weeks. And we are trying to study that a little bit more systematically with using pressure insoles, so we can actually see what patients are up to. So hopefully something will come of that, hopefully, to help us all out.
That's cool. I'll tell you what. So what I've been doing is at 2 weeks, I start motion. And then at 6 weeks, I give them a 2 week by 2 week protocol. So 25% for 2 weeks, 50% for 2 weeks, 75% for 2 weeks, weaning out of the boot, and then as tolerated thereafter. And I give them a physical therapy prescription at their 6 week visit, which the therapists are instructed to use a scale to show them what the percentages are. And people seem to like that because they feel like they're getting something every 2 weeks, and they tend to be, I think, pretty compliant, but that's been my protocol so far. And by 3 months, they're full weight bearing, and they seem pretty happy. So I don't know if it's a patient's happiness thing or they're actually following it.
Albert, Andrew, are you guys doing anything different than what's kind of been mentioned?
No, pretty similar to what Matt just said is what I do.
Yeah, I'm pretty similar. 8 weeks typically for syndesmotic injuries.
Well, Prism, I'm with you. I'm 2 weeks.
Nice.
So they start weight bearing as tolerate at 2 weeks. So we might have some joining papers, sister papers coming out soon because we're enrolling our last patient in that study. So
That's wonderful. Congrats. I think we all just need a little bit of support. So that's great.
So
tell you, like,
what do you use for fixation?
so I use suture button.
1, 2.
Usually just one. But I'm all my ankle unless they're a neuropathic diabetic, all my ankle fractures, doesn't matter what it is, they're going to start weight bearing at 2 weeks. But I'm pretty aggressive with my fixation on posterior mals. I use fully threaded screws on the medial mal. So, but I use just one suture button. And who knows? I might be wrong. We'll see what happens when all these people come back in a year with their CT scans and stuff. But right now it seems to be working. I've not had any fail yet. Well, none in this group. I've had some other people fail, but it was like in diabetics and things like that. I haven't had anyone fail like who is a normal, not neuropathic person.
Interesting. I'll be interested. I would love to let them weight bear earlier, and I feel more confident weirdly with flexible fixation than with screws. I think it's probably going to hold tight. So with my sort of screws and flexible fixation, maybe letting them weight bear, I don't know, 2 weeks to me sounds like it's super early, but I'll let you guys tell me if that's the right answer. But I might do it sooner for sure than 6 weeks or than 8 weeks.
I do think that it is important that it was touched on earlier that length stability is important because the suture button has play. It's specifically made to move a little bit and have some translation, and anterior posterior translation is fine because that's the normal motion of the ankle. But if it's a length unstable fibula, you'll see them shorten, and you'll see that osteolysis that occurs in them, and you can see the tunnels don't line up anymore if the fibula is not length stable. So like if I can't if it's like a Mason or something and I can't fix it into a length stable, then I won't do isolated suture button.
I think that's important, the length stability. And I'll tell you, like in a sensate normal patient, they do self-limit. They really do. You let them weight bear as tolerated at 2 weeks, they're not weight bearing. They're listening to their body and they're limiting themselves as they need to. It's hard to figure out who that patient is, I think.
We have a question that deals with late instability. So like, let's say you fixed an ankle fracture and then you've missed the syndesmotic injury and now they're coming back with instability, or maybe you fixed it and it failed. What is everyone's approach to dealing with that? Are you just going in and putting new screws in? Are you using suture button? Are you reconstructing it? Does anybody have any thoughts on kind of late ankle instability from a missed syndesmotic injury?
It depends on how late. For me, it depends on how late. If it's within the first few months and the fibula was correctly fixed and is out to length, then you don't have to do a fibular lengthening. Then what I would do is I would debride the syndesmosis. I'd probably fix it with flexible fixation suture button device, and that would be my approach for the first 6 months or so. If you're talking late as in a few years, that's more where, and it's not a desirable operation, but I've considered a syndesmotic fusion for those types of patients when it's been years of instability.
I agree with Mark, but I'll tell you the patients that I struggle with are the ones that come in that have 2 millimeters of syndesmotic widening and they're not symptomatic. I don't know what to do with them because I don't, if they at 4 months or 6 months, they're a little wider than they are on the other side. I obviously missed something in the operating room, but they don't have any symptoms. Again, it's hard for me to talk a lot of patients into going back to the operating room for that big surgery to keep them non-weight bearing for a fairly significant amount of time. if they don't hurt, but I don't know if that's the right answer. I mean, I probably don't follow enough of them long enough to see whether they get arthritis quickly, but I don't know. Does anybody else have thoughts on that?
I think that's tough. Yeah, I would just have a discussion with them, like, you know, your risk of arthritis is probably higher, but if you're not symptomatic right now, it is hard to like convince someone to go back for surgery.
That is the time I'm sorry, Prism, go ahead.
No, please go.
I was just gonna say, sometimes, I haven't seen it often, but I think, like you said, maybe there's a piece in there that was, you know, from the original injury or something like that. And sometimes I have gotten a CT that's bilateral at that point to really understand whether it was fixed wrong originally and now has kind of, you know, pulled back because it was too tight, you know, in the beginning, or anterior translated or something. But also to see if there's something, you know, missing, like a fragment in there or something like that, because I have seen that before.
Yeah, honestly, I was just going to say a very similar thing. I'm actually challenged sometimes by the diagnosis. So the patient's still symptomatic. It's sort of a subtle, is there instability, is there not? And I think that that's where the utility of any dynamic type of imaging, if you have that available, can be really, really helpful, or at least a bilateral CT, because the variability, as we all know, in sisuras and syndesmotic anatomy is incredibly variable, but definitely, you know, some pretty substantial evidence to sort of support that bilaterality, so we can use the other side as a template. So I think dynamic, again, imaging if possible, and bilaterality can help at least make that diagnosis as a bony or ligamentous.
Yeah, if they don't have any pain, I'm a chicken, because I can definitely make them worse. I know that. Sometimes I've had patients that haven't necessarily had pain, but they've said that they've had a feeling of like instability when they go down for a squat, or they are having difficulty going up and down stairs, and then that gives me a little bit more comfort in being aggressive. But I'm with you. If they're totally asymptomatic, I always think I can make somebody a lot worse than they are.
I'm totally in Mark's camp. If a patient tells me they're doing well, I ignore the X-ray. I tell them I don't treat an X-ray, treat a person. You're doing okay, you're good.
And then we had one other question about CT, like who is using weight bearing versus standard, like to judge that situation where you have like chronic instability or like a dynamic type CT. I mean, I don't have access to a weight bearing CT scan, but the literature does show that it's beneficial if you have it, especially for foot deformities. But so I'm using standard, but that's just because what I have. Anybody do anything different?
Yeah, I would say kind of the utility of weight bearing and also 4D CT is definitely emerging, but maybe not accessible for everywhere. I think that bilateral CT scan can really provide a lot of insight into diagnosis, reduction, asymmetry between the two sides. The one thing I would say is we're really learning is that foot position really makes a difference. As we know, it's a joint. And so depending on the foot position, the syndesmosis looks different radiographically. So even those contralateral images in the operating room, really ensuring that you're using the same foot position, I think can really be helpful.
I have a question.
Well,
so I fixed my syndesmosis in the foot in maximal dorsiflexion. Is that what everyone's doing? Or are they positioning the foot in a certain way? If you're not doing it open, if you're doing it closed?
I put them at neutral dorsiflexion. I know that the study says you can't over tighten it, but I mean, I don't know if I've seen such unstable ankles that if I tighten it too much, or if I used to clamp them, you can spit the talus out the front in front of the tibia. So I don't know. I feel like the safest thing is to just reduce it in neutral dorsiflexion. And that's how I have someone hold it while I put implants in and all that stuff.
Yeah, I'm neutral.
Yeah, I maximally dorsiflex and I don't clamp, and I say, don't over tighten the screw, just when it feels tight, you're done. I don't know.
I think I'm going to take the opportunity, another plug for the same position as the other side. So I think especially if you're using dynamic stabilization, then just ensuring that the x-rays that you're using on the other side and you're trying to replicate, you're using the same foot position to sort of tighten your device. One thing we did in our RCT was we actually used the ACL tensioning device, and that actually allowed us to standardize. We used 20 newtons, and so you can actually, tighten the dynamic stabilization device and then place the ankle through a range of motion. You can actually see the creep come out of the system, and then you can retighten. And that at least seemed to not result in over tightening in that cohort.
Well, I think we're out of time now, and I would like to, I really appreciate the faculty and moderators. We had to put this together very quickly, and so we appreciate you guys taking time out of your busy clinical and daily lives and vacation time to meet with us and be a part of this journal club. And we'd like to thank all the participants who were asked questions and were engaged. And just remember, you can go and subscribe to the YouTube channel, the AO Trauma North America, to watch this video and other videos and journal clubs. So thank you for everyone who joined, and we really appreciate it.